This is United Medical ACO Weekly event, and my name is Kemal Erkan. I'm the chairman of United Medical ACO. Good afternoon, everyone. Today is October 29th. It's Friday. Our weekly session is on. This is our Delaware health and community updates for our society that we live in. And we have COVID updates, as well as there are some new stuff that we want to share with everyone. And I'm going to have a couple of people joining me today. And then before I start the PowerPoint, we have a new member who's going to be part of this program with me, and I would like him to come up. And then, Sean, if you are able to, please turn your video on. And this is his first session with us, so we're not going to give him a lot of hard time, but he is one of our new members from our business development. Sean Donegan, so part of the business development again. So, Sean, if you can please introduce yourself so then people get to know you.
Yeah, definitely. Thanks, Kemal. So as Kemal said, I am a new member here with United Medical, working on our business development team. So I'm originally from New York. I've been in Newark, Delaware for the past 4 years or so as I attended the University of Delaware. And I double majored there, graduated with 2 degrees. So I have a bachelor's in science with cognitive science, and then a bachelor of arts in psychology. And I was also able to minor in public health while attending the University of Delaware. And during my time there, I was also a member of the University of Delaware football team. So did 2 seasons there. And then after recently graduating, I'm happy to join the United Medical team here in Delaware.
Excellent. We are happy that you're part of the team. And we are going to start with our PowerPoint. So in these sessions, Sean, we do go through our COVID numbers. There are some of them are already provided by our other team members, such as Anthony Anugu and Donna Gunkel and other part of the business development as well. So today we are going to, after the updates, I have some specific update from healthcare. And then we also are going to have Donna Gunkel, our clinical integration director, who's going to be part of our discussion for the patient awareness and what United Medical ACO is doing to increase the patient awareness with the care management activities that we are doing. Now, just looking at the number of cases in the current snapshot of the Delaware, this time I kept I kept the last week's numbers. So let me just actually use this guy here. So this is where we were with the total number of fully vaccinated people. So unfortunately, the total number only went up by 4,000 from last week to this week. Mm-hmm. Now, Delaware is in a good place in terms of the total vaccination. People with 18 and over, at least one dose of the vaccine, we are at 81.5%. That's better than the US average, if I'm not mistaken. Last week, we were at 80.7. The percentage of total population vaccinated, so this is, like earlier what I said, is 18 plus. This is the total population. So we are at 62.1%. Now, what's interesting for us and what we do, some changes based on the certain metrics here is one of them is the positive test percentage. So that's the 7-day average for this week is about 6.2. So that's better than last week. That's 7.6 last week. Now, many people are also interested in total number of actual new positive cases. So that's about 282 versus it was 358. So that means from 1 week, the progress is positive. Now, what's also important here is many people who still have issues with understanding the efficacy of the vaccination. There are some breakthrough cases. So out of this 524,000 cases, there were about 4,600, but this is now 528. This week it is at 528,767. Only 5,100 of those have breakthrough. So, since Sean is new, so I'm going to maybe elaborate some of these things for him as well as for others who may not watch our other sessions. So the efficacy is the key here. So we never, no one actually said that the vaccines are 100% effective. So the efficacy is in the low 90s. In some cases, it's 95, some cases 92. So, but this percentage is still a lot smaller than those projected numbers. So, Sean, what happens sometimes people actually look at these numbers and then they say, well, you see, like this doesn't work. Even the vaccinated people are getting the COVID, but that's never said to anyone, and then also that's not what we are looking for. So we know that there will be some risk group even after the vaccination. But what vaccination will do is it will actually make those cases, perhaps prevent those severe cases. So if that person wasn't vaccinated, maybe they were going to have much severe reaction or severe illness, then now they are able to actually get through that without being in the hospital. Right. Now, so this is our vaccine stuff. And then let me see what I have here. So, okay. So, I have to take those, but I do like the drawing on these, but then to go back to the normal presentation, I need to do a couple of things on the other side. So that's why it's a little bit up and down there. Okay. So this is the number in the total vaccination, our goal of 75%. So 75% is we're still 3 months out of that 75% goal. That's because number of vaccine being given on a daily basis is a lot lower than where it was in March. So March, we were almost at 3.5 million at some point. And then right now we are down to like high 700s. So to get to the 75% immunity, public immunity, it would be about 3 months. But I can tell you that 3 months is going to be another 3 months. 3 months from now. So we always keep saying that's 3 months, but it never gets there. Yep. So, well, this is important. Anthony actually provided me this yesterday for our ACO meeting. The total number of cases and in that unvaccinated versus fully vaccinated. When you look at these numbers, if people don't read, that's one thing, but maybe they can read the pictures. So what we are telling people is that the outcome when you get COVID, the outcome is gonna make a big difference. So if you are not vaccinated, someone dying from that is going to be 100 times more riskier. And then these 2-3 different diagrams is kind of just demonstrating that. So then people who are, the outcome of the unvaccinated is the majority of these cases. So, Sean, we had this term in the middle of the pandemic, at some point after the vaccine was available. So this became the pandemic of those who are not vaccinated. Because when it's available, people should be getting it. And we do have a couple of case studies I'm going to discuss with Donna Dunkel when we do the last part of this session. And there are some cases, it's interesting, while we are trying to manage these patients from different levels, then we also find out that they are actually, they end up going to the hospital. So then everything else that we are doing is kind of like being wiped out. And then patients are at risk situations. And the problem is when you are at that level, the regret doesn't work. So because it's too late.
Yep.
It's already too late. So now there are a couple of things that I want to share with everyone in terms of what's important in the from the news side. So I'm going to bring my a couple of my articles that we wanted to share, and I will share my screen in 2 seconds. We do use Becker's Healthcare as not the only source, but that's kind of our news source, so they are reliable. I hope I'm sharing the right screen. Am I on the right screen? So you guys are seeing the.
Yep. So you can see the framework for the 1.75 trillion.
Yeah.
Yep.
So, well, 1.75 trillion. This is a big spending package. So, when it comes to financial government spending too much, and bigger governments are always, well, in my opinion at least, it comes with its own problems, and not necessarily I'm like fully okay with how much government is actually putting into this, because that's going to come as taxes and other stuff, and then everyone is going to pay in a different way. But the reason for today's discussion is how this is actually changing, what changes in healthcare, how it's affecting the healthcare. So according to Alia Pavalo from Becker's Health, the way that she summarizes is that this would reduce more than 9 million Americans who's buying their insurance through ACA marketplace. Now, this reduction would cut premiums by average $600 per person per year. Okay. Now, what would be helpful? Again, when they say this, it would be helpful to say that what's that total, like $600 per person per year. If it's like $1,000 expense per year, it's 60%. But if the expense is $15,000, that may not be as much. And what happened with the ACA marketplace premiums, in the beginning, it was much affordable. And after the first and second year, it got really expensive. And it's now more expensive than what we are able to provide from our group practices. So, but again, this 600 sounds good, but it may not be that good unless we know the total number.
Right.
So there's also a plan calls for providing tax credits up to 4 million uninsured Americans. So again, many states, they are doing really good with Medicaid, and Delaware actually is one of those states, I would say. However, this is providing tax credit for up to 4 million. So the spending is, if it's investing in the society in one way, but I think it's not. It's more like maybe providing one-time financial relief, and then there are small ones. Like so far, like these two doesn't really do much for me. Like from what I see for people, like when I say not personally for me, but I don't see these two being extremely important. Healthcare has different problems, more important problems. One that I would like to see would be if we were actually working on reducing hospital costs. Mm-hmm. And the other nice thing would be is the medication, really expensive pharmacy costs that we have, which is actually, they're more problematic. Now, this is planning to expand Medicare for people to have hearing benefits. Again, this is 1.75 trillion that we are talking about. So then, so far, there's nothing like tangible. There's like the meat and potato of the 1.75 trillion. I hope this is not it. So the number 4 they have is that there are several items previously proposed, including bill ban, introducing drug reform pricing, and the dental and vision benefits. So this is the only really important one. But when you say drug pricing reform, that's not something that you are going to be able to do by yourself, just from the government side. So it's going to be important to know what that is and what the details of that, because that shouldn't that shouldn't be taking anything out of this 1.75 trillion, because this is just the policy. So when you make the policy, I hope you are not going to spend 200 billion to make that policy.
Right.
So as you can see, this is the issue of the government being in our businesses, especially in healthcare, is a lot worse than many other industries. So, well, as you are going to work with us in the future, you're going to see some of these types of issues, how it's affecting, and why we want to actually have their attention. Being in Delaware, one of the nice things, well, you said you are from New York, but
Yep.
Delaware is, New York has still 2 senators, right?
Yeah.
So, and then we have 2. And then just think about how small Delaware is compared to New York. So in terms of representation from the Senate, we have equal representation. That's also true for California and Texas.
Right.
So Delaware has some advantages from that point, because policymakers are the politicians, and they are saying that I'm going to make a budget of 1.75 trillion spending package, and then I'm going to decide how am I going to spend. So if you don't get involved, and if you don't actually get their attention, and unfortunately, private practices, private outpatient clinics like us, the lobbying is not necessarily as strong as the hospitals or the oil business or the pharmaceutical business. So we have to make sure that they understand the issues that we are going through, because one of our goals with these sessions, as we are trying to reach out to our patients, we also want to reach out to our state officials for them to understand where the real problem is. So it's not going to be as easy as like, okay, well, we'll give this much money to this. So there has to be a more fundamental change.
Yeah, definitely. And also, obviously, everyone's going to have their different perspective, like you said. It's the government's trying to do, a large umbrella approach, as opposed to different states have different needs. It's going to be hard to try to make a one fit all type approach.
Exactly right. So it won't be, because especially with our state structure here, one doesn't fit for all. So everyone has different needs, and well, that's kind of like where we are with this. Now I have a couple other updates, and I like in this just a healthcare update. There's one more that let me just do that as well. I prepped some more for today's discussion, but maybe we'll do them like next week. But one of them is important, and we can actually follow up with that. This is an update coming from Kaiser Group, and let's see if I can find it very quickly. So, and I know that I did actually post that as well, but see, now I cannot find it. So let's see. Okay, so maybe this. So again, this is also important. So the reason I'm actually sharing these is because this is, am I still sharing the screen? No, I'm not. So
I'm seeing let's see, I'm seeing my screen. Yep. So I see the 6 latest hospital lawsuits. Yep.
So you may need to move. So your
let's see. I think our sensor went off there. Give me a moment here.
So this is one of those, maybe in the next several weeks, I do want to bring this up. In our business, hospital is extremely strong and they're powerful, but many people don't understand how powerful they are. And I thought this was interesting. It would be interesting for anyone, at least if they are in healthcare, But even if you are not in healthcare, if the Kaiser defrauded Medicare of $1 billion, like this is one of the healthcare network based in California, I believe. So they are being sued for $1 billion. So again, the main thing is the number 1 billion. Like just think about how much money they will be making. So then they are being sued for 1 billion. So you can just you just come up with these numbers unless the numbers are so big. And this is just the Medicare part of it. So it's not the entire operation. So the Medicare, let's say Medicare is 30% of their total program. That's they're being sued for 1 billion defrauded items such as compliance issues with Medicare Advantage program requirements. And I think that's big, and I would like us to follow this. So like if you can, for our next session, if you can actually bring more updates for this one, this would be important.
Yeah,
but
definitely.
Looking at how many, like the 6 latest hospital lawsuits, so this is another one. This is for hundreds, I believe it was for, one of them was 100 million. So this is more than 1. So well, there that actually is 1.2 billion. That's again, that's not what they are being sued for, but 1.3 billion debt. So how much money they are dealing with? Again, the whole point is when you come to the private practices, the total number is never going to be that big, not even close. But then you go to, there's one other that I saw with 100 million. So, Sean, what we should do is that there are a couple of them that I want us to follow up and then actually provide updates. So then we can actually get a little bit more about what these, what the real reasons is for the lawsuit. So we can actually share those with our audience. So I want people to have a better understanding of hospital systems. So why it's important again. So we are an ACO, right? So ACO is working with the value-based contracts. So what's value-based contract? It's like we are accountable and responsible. Therefore, they are willing to share insurance companies part of their savings with us. Well, only if I have control over, right? So yeah. There's one, you were in the ACO meeting last night?
Correct, yes.
So I don't want to name the institutions yet because I still need to confirm. But the one that I know that compared from 2020 to 2021 in Delaware, with the state hospital, level, with the private hospitals, the increase is per admission is about 50%, one hospital specifically. Yep. So whatever was happening now is costing 50% more. Now, when you look at our reimbursements from the insurances, that's not the case. Mm-hmm. So if I don't have any control, like we don't know why this increase is happening. Now, last year was the COVID year, right? You would expect. Now, again, I may make some references for you being new in this team, but so if you only remember how bad last year was for healthcare and how costly it was for everyone, because once you're in the hospital, your hospital admission would cost more than normal. Right. Now, we are comparing our bases that year. That's our worst year. So. Mm-hmm. And then when I look at this year's total per admission spending, that's actually, it was 56%. It's higher for one specific hospital. Now, again, not knowing and not having any control over that increase, and then being responsible for the total cost of the Medicare or any other insurance spendings, there's a big disconnect. And then that's why when I explain these to other people, they don't understand why we are like sometimes a little bit bitter. Like I know that we sound probably a little bit bitter because we are always fighting with these big giant organizations, and no one is able to hear us if we are not a little bit louder and if you're not loud and maybe clear. So but I do feel much better since we started these live sessions last year. So it's part of my therapy now. So my doctor said that keep doing it. So it's helpful. So now at this point, I'm gonna ask Donna Ganko to join me. Donna, I know you are waiting for us. Hopefully you are still there.
Nope.
How are you doing?
You're still muted. Oh, there we go.
There we go. I thought I clicked both of them. I'm doing good this afternoon. How is everyone?
Good.
Well, thank you.
Well, Shantay, you'll stay on standby, I guess, or you can just stay there. So that's you're fine, either or. So let's see. I needed to make one small update that I missed Donna's name. And I just saw that now. All right, so let's see. This one is here, and see, this is what happens when you don't have, when you are so used to doing things one way, and then all of a sudden now you have to do them all on your own. But now Sean will fix that for us, hopefully, right? So, okay. So Donna, I want to discuss this topic of patient awareness with the patient communication and what United Medical ACO is doing. Now, time to time, we do provide updates. However, unless maybe we explain it in different ways, then sometimes not everyone understands what we are doing. So, and if you are not understood clearly by everyone, it may not be that important if people don't understand, right? Or if you're not able to reach out to them. Now, I assume that everyone already know you, so then I didn't ask you to introduce yourself, but Donna is one of our directors in the, she's in charge of the clinical integration. So now with this effective communication and increasing the awareness, we do several different things, and I just want to go over those with you. And then we have a couple of cases that we would like to discuss from the recent events. So from our case management, care coordination, if you can just summarize that to us, what we do from the United Medical ACO side.
Sure. So we have a care coordination team here in the business office that basically provides back office support for all of our providers, whether they're specialists or PCPs within our United Medical ACO. So we're able to help reach out to patients in order to, so we make phone calls outbound and receive them inbound for our practices to help schedule patients for a variety of appointments, including hospital follow-up appointments if they were recently in the ER or inpatient. We also contact patients to get them in with specialists within our network for their initial consultation. For our Medicare patients, we also reach out and help schedule them for what's called an annual wellness visit, just an opportunity for them to meet with their doctor to do a number of screenings, make sure all their preventive care is up to date, and talk about their ongoing treatment plan. And then we also work directly with the insurance companies and our provider practices as a liaison to help close care gaps, again, for all those preventive services that the patients are scheduled for on an annual basis. And then from our nurse perspective, we have nurses that assist in reviewing the charts to make sure, again, all of those preventive services are ordered. They also review the case to make sure just another set of eyes, like chart prep, to prepare the chart for the providers. So if there's new information that's come in, or if they need to ensure that there's follow-up on labs, radiology, preventive services, that they can help give the provider an update on that to make sure those things are covered.
Now, recently we added another layer of communication, and I do want to share the screen. So then, my goal is if in any cases, if our patients are watching. So then this is another way of reaching out to them. Now, when I actually provided this update, I think it was half of this number last week. So email notification summary, and then there are different types of emails. So what are we looking at here, what it is, and how we are utilizing this?
Right. So we identify as we're talking about the cases, and one of the things we didn't mention is that the nurses, Kemal and I, meet every day for at least 1 hour where we review. We have a case conference, an internal case conference, and then we look for other things that we may be able to do to help support the patient. And part of that is communication with them. So we've developed some email templates that we can generate right from our system. It introduces the patient to their care manager, and it also makes them aware of some of the services and resources that we can provide to them. So it introduces the patient if they're new to our provider network. If they are not active on our patient portal, then we send them an invitation so that it allows for easier communication with their provider team so that they can request medication refills, they can request an appointment with their provider, they can also ask questions of their provider. So there's a number of things that they can do there. They can see normal lab work. It can also be presented to them if everything is within normal limits. So there's a number of things that they can do with the patient portal. We also have some wellness programs, including our diabetes program and nutrition program. So we have 3, soon to be 4. We have a new dietitian starting next month. So we see patients with a variety of healthcare conditions. And so we can provide them with links to resources. We have quick tip videos. We have full-length videos where we have providers from a variety of specialties, including podiatry, optometry, nephrology, cardiology, endocrinology, that talk through the patient's conditions and let them know how those things may be affected by their diabetes. So we provide education links as well as we remind patients if they don't have an upcoming appointment with their PCP, maybe it was never scheduled, maybe they had to cancel it for some reason, and they've never rescheduled it, but they have some outstanding things that need to be addressed by their PCP. So we would send them communication there. We also have one if they have some outstanding lab work that the provider is looking for them to have done prior to their upcoming appointment. So those are just a few reasons that we would be able to reach out to the patients.
So, what I see here is, as you were explaining, I was the one who's kind of knowing these, and then I put a couple marks here. So here's the thing, like while we are actually doing this for patients who are with the multiple illnesses, comorbidities, obviously, 247 out of 400 letters, actually emails, was about the PCP communication.
Mm-hmm.
So if you really think about it, so then the way that I see here is, although, and this is maybe one of the points that we are trying to make, although the issue is we are trying to do the multidisciplinary approach and then bring other people in, other specialties into the case, there's still some disconnect with the PCP follow-up. So this may be, mostly it's coming from our patients. So then because we want, when they leave our offices, we want them to have their follow-up appointments.
Mm-hmm.
And if it doesn't require follow-up, then we ask them to schedule their annual physicals. So then someone may be healthier in, like they may not need a lot of appointments, but this doesn't mean that we won't see them. So this is all about being preventive, and preventing what may be coming. So then we can actually predict what we may need. Now, one other thing that I want to share here related to this one, and then I do want to talk to you about a couple of those patients that we discussed. So with the same logic, same base, we also have, we are doing a lot of a lot of work, kind of like redundant, but in healthcare, redundancy sometimes is needed, and in some cases, redundancy is the only way that you can do these things, because our most EMRs are not so user friendly in terms of the flow of the database management. So we are duplicating. So as we are putting duplicating the orders, or we are suggesting the orders. So we see several one of them here, like cardiology, pulmonary, bariatric. Well, the nutrition is the highest one, but then also like PCP, like going back to their PCP is the second highest. Well, the highest one is the PCP, then second highest one is nutrition. That means we want people to actually get those help from either their PCPs or from the first source of the nutrition. These are because patients with the diabetes, that's one of our focus groups, so that's why that number is high. But then with diabetes, what comes is, well, cardiac and the pulmonary and the bariatric and the psych. All those issues are kind of related to what's happening on the diabetes, or what may be happening around bariatric, or what may be happening. These are all kind of like interconnected disease. Patient has 2, 3, 4 of these problems at the same time. So, well, every time I use comorbidity, Dr. Erkan says when you do it for public use, it's simple terms. So, Dr. Erkan, if you are listening, I was just following what you advise. So, it's when the patient is having so many of these problems, then it's never just one thing that we are treating. So, the problem that we see is we want our patients to listen to the PCP, listen to their primary care, listen to their care manager. So I do want to give you guys an example. This was in August, I believe. It may be in July. It was in the beginning of our program. You know what? Actually, I lied. It is it's in June. It was end of June. So there was a patient who didn't want to get vaccinated. I kind of like this example of this patient just because from the vaccination side to the case management and how those two actually can become worse if patients don't follow what we are advising them. So this is one of the examples that I thought it would be good to explain and put it in perspective for everyone. So patient is in the mid-70s, and the only reason I get involved with them is because they had a little fight with their primary care physician. And because primary care physician didn't feel safe with unvaccinated patients and doing in-person visits, and as much as it's necessary, it can be done through telemedicine, he wanted to keep them on telemedicine. Well, patient got upset because they want to be seen in person, but they're also refusing to get vaccinated. Now, this patient is in their 70s, and it would be a perfect candidate for vaccination because like the priority of number one is 65 and over, and this would be that. So I was tasked to call the patient, and I did, and there was the significant other on the other side of when I was talking to her, significant other was yelling and screaming, and that we are the Illuminati, and then we are trying to get everyone vaccinated, blah, blah. So in the meantime, I just checked her lab values, and her cholesterol was out of control. And I said, look, we'll fix this problem with vaccine. I understand you don't want to be vaccinated, and I understand that you think we are crazy. However, your cholesterol is going to kill you. So can we actually take care of that problem? Then I was able to get her an appointment. And then she was back to normal. She did only one follow-up with the nutrition and then didn't follow up with the others. Now, the interesting thing is when I was talking to her, she said, well, I know what I'm doing wrong anyway, so I'm just going to cut off the cheese and then all my cholesterol will go back to normal. And what I said is that this is really high. I don't think the cheese adjustment is going to get you where you need to be. Let's make sure that we control this. So that's the part that we are doing with our care managers so that they are trying to get these patients. Now, Okay, now why did I even bring this patient up? Is because patient actually is now in the hospital. So this is a mid-70 with 3 chronic problems, and 2 of them are like at the highest level uncontrolled, and she's in the hospital. Now, my question, Donna, to you, maybe like, not to you, like I know that we don't have a solution, and you and I we are on the same page with these patients. Problem is, well, here's someone who doesn't want to be vaccinated, fine, but doesn't want to also follow other health advices that we are giving them, consults from their primary care. They're not following that. Now they're in the hospital. The hospital right now for a 70-year-old, 75-year-old is not safe, right? So, like, I wouldn't want my mom to be in the hospital right now if it's not some urgent situation. These are all preventable. Now, could we do something different for this patient?
Right. So I think one of the things that you say there is it safe? I think anyone who is elderly, they aren't vaccinated, they are at risk or at a higher risk, and usually are immunocompromised. So we wouldn't want to put them at risk if there is something, to your point, that can be prevented. So by going to their PCP frequently, like they're supposed to, getting the lab work done that they should get done, and following the treatment plan. I think that's really the key there is, sometimes we may say we don't have time, or that's not important, or I'm going to eat what I want to eat, or I'm going to do this. But unfortunately, it does put us at a higher risk for those types of things. And the very things we were trying to get this patient in with our PCP for is the very reason, unfortunately, she's in the hospital today and now could be potentially at risk for other things. It is flu season as well. COVID, obviously, the numbers are still high. So we just want to make sure that our patients understand our communication to you, our involvement with you is really to help enable you to live a longer, healthier life. And so those things, whether they be preventive or making sure you're taking your medications the way you should be to keep your blood pressure, your cholesterol, any number of other things under control, is really the purpose of that. And I guess why we're talking about that, Kemal, one of the other cases came to mind for me. If you remember, we also look at our Medicare patients. And one of the things Medicare does is they offer what's called an annual wellness visit, and it's covered 100% by Medicare. And the purpose of that, as I kind of mentioned a little bit earlier, is that patients are having all their chronic conditions assessed, even if they're seeing a specialist that's pulling it all together, right? The PCP should be looking at all the different medications and all the different treatment that's being done by all of the specialists. And being aware of that, also making sure that preventive services are being done. So my point in bringing this up is we had a patient, and so we called him, actually I called him, if you remember, Kemal, during our case conference. This gentleman was Medicare age. He was seeing his cardiologist 2 or 3 times a year, who is also in our network. That's how we knew he was being seen. But he was not seeing his PCP, who again was in our network. So we reached out to him just to try to understand, like from his perspective, why he was not following up with his PCP. And he actually told us that, oh, well, I see my cardiologist and he does my lab work and he orders my cardiology medication. So I thought that's all I really should be doing. And so we needed to remind him how the PCP is looking at the whole person. And specialists are usually focused on that particular specialty, right? The heart, the lungs, whatever the case may be. And advising him that, yes, his cardiologist was doing lab work, but it was strictly all cardiac related lab work, that he wasn't getting some of the other lab work done that could potentially uncover any number of other issues that he may be having. And so through that dialogue, he's like, I should do that. I should call and schedule an appointment with my PCP. So it's just another, I guess, example of how communicating even one-on-one there was, we were able to provide him with additional education.
I would have told that patient that your cardiologist has a PCP, right?
Sure.
So for their issues, I think that's again the perception problem, right? So from the patient standpoint, so cardiologists who went to school 3 more years, or they're
Or he's like, I'm seeing a doctor, they're doing lab work, I think everything's good,
But after that residency, that 3 year is helping them to specialize in something else, which actually makes them less maybe knowledgeable on the primary care issues because they are focusing on something else. So I would say that cardiologists, yes, they know more about cardiology, but when it comes to the internal medicine, family medicine, that's a different ballgame. And then knowing everything that's happening with the patient, that training, and also not just the training, but that's daily practice, like daily repeat. Every patient that you see is another experience. So that's the role of the PCP is the core center of your care. And now I'm sharing this number. These numbers, what they represent is number of admissions in the hospital. So if you look at the total number in August, right now, this was 2,300 total admissions. So now in January, we were at 1,825. In August last year, we were at 1,758. Mm-hmm. Now, it is true that some patients, they are not going to the hospital emergency rooms, but not how many patients we have who are going to the ED, like if that's their PCP or their little urgent care.
Right.
So how many patients who are just freely just walking into an ED, they get the service, they don't have to pay anything extra, and the hospitals are getting the big dollars. And then we are trying to, we are trying to do this session to reach out to our patients to increase the effectiveness of our communication and then make them more aware. So there are so many bits and pieces that's missing, disconnected. Actually, one of the things that when I was talking to Sean earlier, so the biggest expense is in the hospital and the pharmacy side of the business. So when you look at those where the money is being spent and the control of that, those spendings are not in the provider's hands. That's on the organization that they are in charge. So we are really fighting without having much power in the system. So that's one of the issues. So Sean, I know this is your first professional job after college, right? So you didn't work anywhere else after college. So maybe this is going to discourage you not to stay. But because you are a football player, so then that means you love to fight and compete, right? So yes. maybe actually this is good to have someone who's part of the team who's actually kind of going to see this as like the challenge. So it is a lot of unfair setup that's already happened, and then we are trying to undo those by communicating with the right people and then being loud and clear about what we are saying. So hopefully more people are hearing this, and then we'll address some of these things in the next several weeks with different people.
I just want to say one quick thing, maybe 2 little quick points, Kemal. So one, to your point, when a patient with a non-urgent, so we're not talking about the chest pain, the severe, abdominal pain, we're talking about the day-to-day things that they could see their primary care for is, one thing is for patients to be aware that most practices set aside a certain number of visits every day for sick visits so that they can get you in quickly. So that's one thing that you should call your primary care and see if they can see you within, that day or the next day. And the other thing I think is you have to remember if you're going to, the ER for primary care types of things, you're seeing a different provider each time, whether it's a physician, a PA, you're seeing someone different. So they don't get the opportunity to know you and, your history in depth. Yes, they're going to take a history from you, but your primary care is the one who really knows the most about you. And so probably can more quickly and easily get to the treatment plan for you. So those are just a couple of additional educational things that we want to make sure patients are aware of.
All right, so we lost Sean to the electricity. So,
there we go.
well, both of you, thank you so much for joining me today. So this was a good discussion. And we have another session with our Bariatric Friday. Dr. Erkan actually is in Canada today. And we are going to try to see if everything's going to work with his setting. And he's just messaging me now. So we'll be back in 3 minutes on the other channel. So thank you for joining me. And then, well, happy Halloween and have a nice weekend.